Next presentation.
Now I invite Dr. Anushka Prajapati for her case on progressive outer retinal necrosis associated with Herpes simplex virus in a PLHA case.
Respected delegates and faculties, good morning. I am Dr. Anushka, resident doctor from Gujarat Institute of Medical Science, Bhuj. My case today is progressive outer retinal necrosis with herpes simplex virus in PLHA patient. Progressive outer retinal necrosis is a rapidly progressive necrotizing herpetic retinopathy typically seen in severely immunocompromised individuals. It is characterized by initial geographic opacification of the deep peripheral retina without prominent vasculitis or vitritis, followed by rapid progression to involve the entire retina. It is commonly associated with varicella zoster and uncommonly with herpes simplex. It usually presents unilaterally with bilateral involvement as the disease progresses. The visual prognosis is poor as the disease progresses to retinal detachment. This case is of a 33-year-old Hindu male patient with complaint of diminution of vision in right eye since 3 months. The defect was sudden and painless. The patient is a known case of PLHA since 1.5 years on antiretroviral therapy. He is a habitual tobacco chewer since 10 years. There was no other drug use or systemic illness or any significant family history. On examination, the visual acuity in right eye was 6/60. The left eye was 6/6. RAPD was present in right eye. 15-degree exotropia and alternate exotropia was present in right eye. On slit lamp examination, the anterior chamber was quiet and no significant findings were found. Dilated fundus examination was done after that. The fundus findings are 360-degree blurring of disc margin, mild vitreous haze, multiple deep whitish lesions in the peripheral retina, and a few coalescent patches of retinal necrosis. The retinal vessels were spared. OCT was done. It showed outer retinal disorganization with posterior vitreous detachment and mild vitritis. The blood work was done, which showed mild leukocytosis with CD4 count was in 800s. Varicella zoster markers were negative. HSV1 and HSV2 were positive, as well as CMV was positive. The patient was started on intravenous injection acyclovir 500 mg in 100 ml NS. The patient was also continued on tablet dolutegravir, lamivudine and tenofovir once a day. The progression was rapid deterioration of the condition with the vision dropping to hand movements, perception of light and faulty projection. Repeat fundus examination revealed formation of tractional band superiorly towards the macula. Thus, the findings were right eye with visual acuity of 660, RAPD, fundus showing multiple whitish necrotic lesions with mild vitritis, OCT findings showing RP disorganization, and viral markers showing HSV1 and 2 association in a PLHA patient with CD4 more than 800, with rapid progression to visual acuity of HMPL-PR inaccurate with development of tractional band. The differential diagnoses were progressive outer retinal necrosis, acute retinal necrosis, and CMV retinitis. The other two have more vitreous component and the vessels are not spared. Progressive outer retinal necrosis is a rare clinical entity seen in immunocompromised. Documentation usually shows association with varicella zoster and less commonly with herpes simplex. CD4 counts are usually on the lower sides around 100 per nanogram. This case here is unique that the CD4 counts were in 800 and the zoster was negative. It is important to screen patients with known factors such as PLHA patients for retinal pathologies. Prompt diagnosis and treatment are necessary to limit the retinal damage and preserve vision. More vigilance and awareness can prompt quicker vision saving action.
Dhanashree, Sangeet, comments? Differential diagnosis, POR and CMV. Yes.
What is the titer of CMV that you consider significant in this case?
Sorry.
Because the titer is very low. Just asking that in any case of PLH or any other case of non-PLHA, what is the titer of cutoff titer that you consider significant? Because CMV is very, pan present. In many cases, you can see low titer positive.
So I think there is no role of CMV titers in diagnosing CMV retinitis. Okay, no value except PCRs. So absolutely no value of getting your IgG, IgM levels done. So this is absurd. That is one point. And basically CMV is purely a clinical diagnosis,
Yes,
but
sir,
yes,
hemorrhagic
PCR
presentation.
could be a helpful tool. But other than that, there is no other any investigation which would help for CMV diagnosis.
May I add a point?
Yes.
Hi, Anushka. Good presentation. This case, though the diagnosis I would differ, it looks like a case of acute retinal necrosis only, because ARN can happen in PLHA patients, and you said there's an amount of vitreous inflammation, and the lesions are a little more peripheral. So PORN, it was described in early 1990s, and that time we did not have OCTs. So it was described as an outer retinal involvement of the macula, where in very severely immunocompromised patients where the CD4 count is very less, maybe less than 50 or 100. So they don't have any immunity.
Yes.
So they present as lesions in the macula where you can see the vessels passing over them. So clinically, it looked like an outer retinal necrosis. That time we did not have an OCT. So I'm Dr. Spurti Mandadi. I did my Uvea fellowship from LVP in 2018.
But it's not always posterior pole, because
Yes.
we had done PORN, came out in the era of HIV.
Yes.
And I did my fellowship,
Yes.
and we were the first to present PORN. Usually in those cases, it was periphery, outside the arcade. It's actually not the posterior pole disease.
So we have now recently published a paper where we have correlated the OCT findings of the classic PORN cases and shown that the involvement is actually inner retinal and outer retinal and total retinal involvement. So maybe it is a misnormal that we.
So recently there's a publication
Yes.
mentioning that you
So we
need to
collected
change
those
the
cases, yes.
terminology.
Yes.
Thank you very much. I think we'll move on to the next presentation, which is
So now I invite
presentation.
Dr. Abhishek Heranjal for his talk on case-based insights, aflibercept in managing DME and wet AMD. There is a small announcement. I got a lost car key of Honda car. So if anyone's key is missing, kindly contact me. Honda car key.